My name is Stephanie Costanzo, and this is my case study, Acute Care Edition. My fieldwork site was in acute care, a hospital with 303 acute care beds split into 5 floors. The OTs primarily administered the assessments, and then the CODAs primarily performed the treatment sessions. I did perform some treatment sessions while at this site, but I primarily administered the evaluations. And these evaluations were either done independently or as a co evaluation with the PT, depending on the patient's status. The role of OT was to assess the patient's level of independence and, based on their identified deficits, determine the support and services that they needed, as well as equipment to have a safe and successful discharge from the hospital. Types of populations and diagnoses that I saw throughout my time at my site was neurological conditions such as stroke, TBIs, spinal cord injury and seizures, orthopedic conditions such as hip and knee replacements, fractures and multiple trauma, cardiopulmonary conditions such as heart failure, COPD, and MIs, surgical recoveries from abdominal surgery, cardiac surgery, or spinal surgery, thoracic surgery. ICU patients, which is like prolonged bed rest, delirium, or deconditioning, infectious diseases such as sepsis, and then cancer diagnoses. And then the equipment that I commonly used throughout my time at the site were two-wheel walkers, gait belts, sock aids and reachers, long-handed shoe horns, supplemental oxygen, bedside commodes, and a slide board. Patient A is a 68-year-old female with diabetic ketoacidosis. Patient was brought to the hospital with necrotizing fasciitis of the right lower extremity. She underwent a guillotine amputation for source control. It was in the ICU for multiple days on pressors, and the doctor discussed a new plan to convert to formal right, aka. Her medical history is CAD, CHF, chronic cutaneous venous stasis ulcer, diabetes mellitus, disorder of the kidneys, hyperlipidemia, hypertension, infectious disease or MRSA, and then a non-STEMI. Her past surgical history, which led her to today, from 2022 into 2025, she underwent a right amputation, partial first ray, right foot amputation transmetatarsal, and then a right debridement leg infection, incision and drainage of the right lower extremity, debridement of the right foot, debridement of the right foot wound, a partial amputation of the left great toe. And then after being brought to the hospital this past time, she went through a right through the knee guillotine amputation, which then was converted to a right, aka 7 days later. The social history for patient A is that she lives alone on a one-level single-story home with 2 steps to get into her house. She has a walk-in shower with a handheld shower head and grab bars, and a standard toilet with no grab bars. She currently has a tubal walker and cane at home. She has no home supplemental oxygen. And patient reported her prior level of function was independent with all BADLs, IADLs, functional mobility, and driving. Patient reports that she was married and has 2 sisters and 1 brother. She worked at a restaurant, bussing tables, and has a cat. She has 2 daughters that live in New York, and she's estranged from them, and she doesn't speak to her siblings as well. So the patient does have a low support system. Complaints and difficulties. Patient initially reported to the emergency department with concerns that she couldn't take care of herself at home and she had a foul smelling right foot wound. Patient stated that she had a difficult time and fell and was unable to get up, and that she crawled in the bedroom and called EMS. She has a history of diabetes and was not currently taking medication, and at time of admission her glucose level was over 600. Following surgery, patient reported that she felt numb and she feels abnormal, even 10 days following the surgery. She is slow to answer orientation questions, and she is reporting phantom pain in that right lower extremity that has been amputated. Patient A's impact on functional ability at this time, with her current disposition, all of her areas of occupation are severely affected. For her BADLs, self care tasks such as bathing, dressing, grooming, and toileting are significantly impacted due to the right lower extremity being amputated. She's having phantom limb pain, fatigue, and cognitive impairments. She has impaired balance and strength limitations in are affecting her independence with transfers and mobility. Although the patient has some home equipment, in her current position right now, she requires max to total assistance with most BADLs, indicating that she has a loss of independence. For her IADLs, due to impaired cognition, medication management, household tasks, and driving are likely to be dependent due to her physical limitations and poor diabetes management prior to her coming into the hospital. Her functional mobility, loss of that right lower extremity, the recent two surgeries within 7 days, and her poor endurance can contribute to significant mobility deficits and affect her transfers and ambulation. And then also environmental barriers for functional mobility is that she does have a two-step entry and a standard toilet with no grab bars, which could prevent safety risks and accessibility changes. Her health management, she's not managing her diabetes as she came in without taking her diabetic medication. And she has, uh, due to her cognitive decline after surgery, she may have poor insight to needing further medical care prior to, or following discharge. And then she does have a cat at home, not being able to currently be mobile as well as have endurance limitations can affect the ability to care for her cat. The OT assessment for patient A was completed day one post op of the right AKA, so 7 days post op of the first surgery. And it was completed by myself and my CI along with a PT as a co evaluation. It went well for what the patient went through. She went under anesthesia twice in 7 days, so that could impair her cognition. She kept expressing that she felt numb, abnormal. She thought she was having stroke like symptoms. We performed some assessments that would demonstrate if she may have had a stroke, and everything was coming back negative. We did inform the RN of her concerns. She received pain medication prior to us going in. I don't think anything could have went better from what we did. We had to do a lot of redirection to keep her attentive to tasks because she was focused on not feeling well. She had right leg phantom pain. She had to be told multiple times that she did have her right leg removed because even after looking at it and feeling it, she was had a very flat affect. She didn't seem like she understood what we were saying. So, something I learned from it and something I was surprised from was that having to do frequent redirection with someone that's gone through that, even though they don't understand that you're telling them that they've lost their leg, but continuing to repeat it helps with the redirection and kind of focusing them on the path that we want them to go on. So, the reason for the referral was she had the right AKA with weight bearing status of non weight bearing on the right lower extremity. Her assessments and observations, she scored a 8 out of 10 on her amp, or 8 out of 24 on her AMPAC. The AMPAC breaks down into 6 categories. So putting on and taking off lower body dressing, she was a 1, which would mean total. Bathing is a total. Toileting, she had a Foley, and then she was going in a brief and having to be changed. So that would be total. Putting and taking off clothes, her right and her left upper extremities had edema, and she had minimal range of motion, active range of motion. She was able to bring her hand to her face with elbow flexion, but she had trouble brushing her hair and reaching over. So that would be total. And then taking care of personal grooming, she was able to do some seated. So that would be a lot of help. And then eating meals, we saw some self feeding. So that was a lot of help. So that'd be another 2. and that would be a total of 8. So the patient required a total assist for bed mobility, a total assist for toileting, a total assist for lower body dressing, max assist for seated grooming, and moderate assist for self feeding in bed. She demonstrated poor sitting balance at the edge of bed and unable to attempt a sit to stand. Patient was independent with BADLs prior to hospitalization and now experienced shortness of breath and O2 desaturation on room air during routine tasks requiring pacing, frequent rest breaks, energy conservation techniques, and supplemental oxygen. Patient demonstrated impaired cognition as evidenced by it had impaired safety awareness to facilitate proper techniques and body technique or body mechanics for transfers and functional mobility. And then she had difficulty following one-step instructions and sequencing during grooming and self-feeding. The patient sustained had difficulty sustaining attention for more than 2 to 3 minutes. Like I previously said, she was focused on the phantom pain and that she was feeling abnormal. That affected her participation in ADLs, and the patient had poor insight and judgment, placing her at risk for safety issues during ADLs and functional transfers or more mobility. The patient was unable to state recent surgery despite being reminded multiple times throughout session, and she was educated on energy conservation techniques, proper body mechanics for bed mobility, and verbal cues and physical cues for sitting balance to maintain midline and sequencing for grooming and self feeding activities. So, for her plan of care, where we recommended moderate intensive therapy, which includes 3 to 5 days of therapy while in the hospital and demonstrates a recommendation for a placement in a facility for further assistance. Other details that were gathered throughout the evaluation was that the patient did not use any assistive devices at baseline. She was oriented times 3 and disoriented to the situation. She had bilateral upper extremity pitting edema throughout, and then her right upper extremity shoulder active range of motion was approximately 100 degrees, and her left shoulder active range of motion was approximately 85 degrees, and then her wrist, elbow, and hand active range of motion was within functional limits. Her gross strength was a 3 minus of 5. For her plan of care, the patient would benefit from skilled OT services to improve her endurance, reduce her pain, increase strength, improve functional mobility, enhance cognitive ability, improve safety awareness and insight to disability, and to teach proper body mechanics and positioning to prevent further injury and promote and regain independence during daily activities.
Short and long-term goals that were developed for patient A include patient will perform static and dynamic sitting balance for 5 minutes or more at edge of bed with no loss of balance, to perform upper body ADLs, to perform bed aerobic with modified independence, to demonstrate the ability to feed herself using her dominant extremity with supervision, to demonstrate her ability to groom seated with supervision/setup, to safely perform stand pivot transfers using max assist using a two-wheel walker, and then her long-term goal is to improve her functional independence and her BADLs to a level that requires minimal assistance or less within a seated or supported standing position as appropriate to support safe and return to prior level function.
This is patient A's intervention session note 1, discussing her first intervention session after her initial assessment. For intervention session 1, the goals that were addressed were bed mobility, self feeding, sitting balance, and seated grooming. The preparatory methods that were used included hand over hand assistance to facilitate her engagement in grooming and feeding activity, verbal cues and frequent redirection to support her attention and cognitive engagement during the activities, co-treatment with PT to optimize her physical readiness, promote posture stability, and ensure safe mobility when going from sit to supine, supine to sit, positioning techniques to improve her tolerance in an upright posture and participation in her ADLs, and then her environmental setup and cueing for task initiation and task completion. Methods used was the rehabilitative frame of reference to emphasize compensation, adaptation, and safety while maximizing her independence in her ADLs despite her impairments that she is currently experiencing. And then the intervention activities that we performed throughout the session was sitting grooming with washcloth, supine in bed, sitting unsupported at edge of bed, bed mobility, and hand over hand assistance for grooming activity. During this session, patient made progression towards her sitting balance goal, her bed mobility goal, her ability to feed herself goal, and her ability to groom seated. Education was provided for energy conservation principles, proper body mechanics, and during bed mobility, and verbal and physical cues for sitting balance to maintain midline posture. There currently is no update on the plan of care, and her impact was 7 out of 24. This is the intervention session 2 note that was created to discuss where she had improvements in her activity tolerance and functional mobility and improved her impact score and continued to recommend moderate intensity for her functional deficits. Goals that were addressed during this session was bed mobility, self-feeding, sitting balance, and seated grooming. Preparatory methods that were used was verbal and tactile cueing, to promote motor sequencing and trunk control, positioning for sitting balance and activity tolerance, positioning at the edge of bed to support sitting balance and activity tolerance, and then using multiple therapy sessions throughout as a moderate intensity will address those underlying deficits to increase our strength, endurance, and cognition. The rehabilitative frame of reference was used to maximize independence of ADLs and IADLs despite her current limitations, to use compensatory strategies needed to assist with her activities. Intervention activities that were performed was seated at edge of bed to improve activity tolerance and sitting balance, grooming and self-feeding sitting at edge of bed, sit to stand with two-wheel walker with cues for proper sequencing and hand placement, and then functional mobility training to roll and sit to supine. During this session, patient progressed towards the following goals: sitting in dynamic sitting balance, bed mobility, the ability to self-feed, and then seated grooming. Energy conservation strategies and safety awareness for ADLs were educated to the patient due to her fluctuating oxygen levels and decreased endurance. And then no plan of care updates were made during this session. Impact was 10 out of 24. This is the intervention session note for her third intervention session, talking about her improvements in bed mobility and ADLs and self-feeding, but also her deficits on her psychosocial aspect and her ability to perform sit to stands. The goals that were addressed in intervention session 3 was sitting balance, bed mobility, self-feeding, specifically beverage management, and seated grooming. Preparatory methods that were used include verbal cueing and frequent redirection to support initiation and engagement in activities, task segmentation and encouragement to help her build confidence, and reduced fear avoidance behaviors such as her I can't statements that she stated throughout the session, hand over hand assistance to facilitate motor planning and task completion during her grooming and lower body dressing, positioning strategies to help maximize her respiratory function because she was put on oxygen throughout her time at the hospital, and then pursed lip breathing activity techniques to cue and manage her shortness of breath and improve her oxygen saturation. Methods used was the biomechanical and cognitive behavioral reference. Biomechanical to address her physical deficits, to increase her strength, endurance, and postural control during her activities, and then cognitive behavioral to address maladaptive beliefs and self-efficacy to through encouragement to help participation in meaningful activities despite her I can't statements. And then her intervention activities for this session was beverage management, seated grooming, sit to stand, bed mobility, and lower body dressing. During intervention session 3, she did make progression towards the following goals, which was her sitting, static, and dynamic balance, her bed mobility, her ability to self feed, and her ability to groom while seated at edge of bed. Patient education was that patient was put on 1 to 2 liters of oxygen via nasal cannula, and the patient was educated on how to purse lip breathe. And then the patient was cued to perform purse lip breathing to increase oxygen levels. There was no plan of care updates, and her AMPAC was a 10 out of 24. For her discharge plan was to be discharged to a skilled nursing facility in Fort Myers, Florida on 6/25/25. At the time of admission, the patient had undergone a right AKA, and her occupational therapy evaluation was completed 1 day post-op. By discharge, she demonstrated improvements in sitting balance, bed mobility, seated grooming, and transfers with an AMPAC of 11 out of 24 compared to her initial evaluation of an AMPAC of 7 out of 24. The final goal progress that she made, she was able to meet her static and dynamic sitting balance goal, and she progressed from total assistance to moderate assistance for her bed mobility, progressed from total assistance to min assistance for ability to self feed, progressed from total assistance to minimal assistance with her seated grooming, and then no progression towards her stand pivot goals. She was a total during eval and then a total at discharge. As I reflect on my fieldwork experience during this acute care rotation, I had the opportunity to work with a wide range of diagnoses. But the one client that stood out to me was the case study that I did of the patient that was an amputee. Although they didn't meet all of their therapy goals, she demonstrated meaningful progress in functional mobility and self care prior to discharge. Working with this client taught me the importance of celebrating small improvements and recognizing each patient's individual journey. Something that went well was my ability to build a rapport and adapt interventions to meet her goals as they changed as she progressed throughout the time of her hospital stay. If I could improve anything, it would be developing more confidence in navigating a time sensitive documentation and medical equipment. So being able to document appropriately. This was more throughout my entire experience. As I progressed through, I documented faster, but making sure that I understand everything that needs to be in there and in a timely manner because of the way productivity is. And then this experience strengthened my understanding of the role of OT in acute care and the importance of patient care during their different transitions and how everyone is different and you have to model and mode shift to be able to appropriately work with them even if it's just for an evaluation.